Yeah. So good afternoon. Thank you, Dr. Eller. So my name is Carlos Perez. I'm one of the second-year ID fellows. So we're presenting the ground round today. Is titled is double-edged sword. So basically, this figure gives a good description of what we're going to be talking about. So on the blue side, you will find some different type of cancers that have been linked or associated with some type of bacterial infection, right? In the other side, on the red side, actually you will see some bacteria that are currently being studied. Some of them actually being approved already for treatment of cancer, some type of cancer. So in the first half, we're going to be talking about all this infection that carry higher risk for cancer, and the other half will be talking about treatment with all this type of bacteria, even some viruses. So let's start. So we know that this is Burkitt's lymphoma, right? So we know this is something is lymphoma is associated with EBV, right? So basically, the way that was found actually was because one of the surgeon called Dennis Burkitt, he was working on Uganda, and he found that this new type of lymphoma actually was he found that it was more prone in some different places. So he thought maybe it's something in the environment, right? Then realized that most of these patients were actually co-infected with malaria. So he thought maybe there's an infection, a virus that is driven this lymphoma. So Epstein is the one on the right side. Actually, he was a biologist. He was working with some chickens and trying to see the relationship between sarcoma and the viruses. So he was interested in the theory of Burkitt. So they started working together, and with the help so Asian is one of the colleagues in the middle, and Barr is the lady on the other picture. So they were able to identify the virus in the lymphoma, right? So in 1964, basically they published the first evidence of a virus causing human cancer cells. So it was called Epstein Barr. I don't know why actually Asian was left. I don't know, but yes, I don't know. But yeah, it was the first evidence of actually an infection causing a cancer. So obviously, it doesn't mean that we have EBV or mononucleosis. Eventually, we're going to have cancer, right? There's a lot of steps between. The most important thing actually is the host, right? Who's infected, a lot of different exposure. But there's evidence that there's a lot of infections. It could be viruses, bacteria, and parasites actually have some proteins that are oncogenic by itself. Also, the inflammation, you have a chronic inflammation, chronic infection, you will have constant DNA damage, right? So you're more prone to have mistake when you are repairing. So you'll have mutation that eventually will progress to cancers. But one of the most important pathway regarding the cancer is the NFKB. This is a busy slide, but you can see basically it's involved in a lot of stuff. Inflammation, apoptosis, T cells. So this pathway is constantly promoted when you have a chronic infection. So let's start with EBV. So this was the first human oncogenic virus discovered. I was actually surprised that around 1 to 2% of all the cancers are secondary to EBV. 95% of the population is actually have been exposed. The key here is that EBV stay latent in the lymphocytes. So go integrate into the DNA. Also, eventually will immortalize the B lymphocytes. So you will have proliferation, transformation, and there's a lot of type of cancer from Burkitt's, Hodgkin, PTLD, nasopharyngeal, and gastric cancer. But one of the properties that make EBV so oncogenic is that it's able to infect different cells, B cells, natural killer T cells, also epithelial cells. Another one is H. pylori. We know the relationship between H. pylori, gastric cancer. The one that normally we get asked is MALT lymphoma. So actually, they found the H. pylori produce a toxin. It's a virulent factor we call Ka. Actually, this factor basically will cause a mutation in the p53 protein and the APC. So basically, that's a key step regarding how H. pylori promote cancer formation. Also, they found interleukin-1 is highly produced, and also interleukin-1 is basically it's involved in a lot of autoimmune disease, also different type of cancers. papilloma virus, HPV. Normally, when we think about HPV, we think about cervical cancer, but we have to remember also oropharyngeal cancer, anal cancer, vaginal cancer, penile cancer also are secondary to HPV. The serotypes 16, 18, and 18 are the ones that carry the higher risk, but we know there's a lot of serotypes. Around more than 10% of the population is actually aptly infected. 35,000 people are diagnosed with HPV-related cancer every year, and around 4,000 women die of cervical cancer, secondary to HPV. And the thing is that vaccination could actually prevent more than 90% of the cases. So the pathophysiology is pretty simple. You have the infection, the HPV will go to the epithelial cells, integrate in the DNA. Sometimes the body is able to just clear the infection, but sometimes it could be early as 10 years, as late 30 years, eventually will cause neoplasia or actually progress to cancer. So does anyone knows this condition? Actually, Andrew, you mentioned this one. So this is epidermodysplasia verruciformis. So this is a rare autosomal recessive disorder that is actually related to chronic HPV infection. The serotypes that normally are involved are the HPV 5 and 8. So of these patients, 60% eventually will have a squamous cell carcinoma secondary to the HPV. So HPV-8, right? We know normally it's known for Kaposisarcoma, right? But although we always think about KS secondary to AIDS, it was actually first described on the 1872. It was elderly Jewish man in Austria. So that's what we call a classic sarcoma. Then we have the epidemic in California, New York, 1981, that they eventually in 1994, they were able to isolate the HHV-8 on the Kaposisarcoma lesions. It's pretty impressive that before ARTs, 1 of every 3 patients with HIV actually will have Kaposi. Now it's very rare, right? We still have some patients, but it's not that common. In the United States, less than 10% of the population actually is seropositive for HHV-8. On the Mediterranean, it will be 30%, and in Africa, about 50%. On Africa, so 80% of the Kaposisarcoma are from Africa, and it is called endemic KS. Another condition related to HPV is primary fusion lymphoma. It's around 4% of HIV-associated non-Hodgkin lymphoma, but it's very rare if you don't have HIV. It's less than 1%. It's a male predominance 6-to-1. And actually, when they take samples from the fusion, around 90% of the cases you will find EBV. So they don't know if this is just incidental finding or is actually contributing to the lymphoma formation also. This will be Castleman disease. We know we have different types of Castleman. The one that is associated with HHV-8 is multicentric, around 50% of the cases. So Castleman is not by itself a lymphoma. It's just a lymphoproliferative disorder that goes to the lymph nodes, will cause angiofollicular hyperplasia. And most of the symptoms are because of secretion of interleukin-6. But sometimes this patient eventually progresses to lymphoma. So hepatitis B, Hep C, we know hepatocellular cell carcinoma. Around 350 million people are infected with Hep B, and of those, around 300,000 deaths related to hepatitis B and liver cancer. On the other side, hepatitis C is around 100 million people infected yearly, with around 170,000 deaths. HTLV, we know it's a type of retrovirus, the same as HIV, right? So mostly it's endemic on Japan, Caribbean, especially Jamaica, South Central America, and Africa. So HTLV actually is associated with, if the patient is co-infected with HTLV and HIV, they progress more quickly to AIDS. Sometimes some patients, they don't respond to the ARTs, and the reason is that because they're actually infected with HTLV. We know that also another disease will be HTLV-associated myelopathy or tropical spastic paraparesis. And the one that we have seen probably Moffitt, a few cases, is adult T-cell leukemia lymphoma. So here you see the cancer cells. This is called flower cells. It's pretty pathognomonic for this type of cancer. So it may think nothing is 100%, but almost all the cases of ATLL patients are infected with HTLV. But of those infected with HTLV, less than 5% actually will have the malignancy. And the survival could be less than 1 year, so it's a pretty aggressive cancer. Merkel cell Papilloma Virus. So around 40 to 80% of the population actually is seropositive. But some people actually argue that this is part of the human skin microbiome. So, but obviously it is associated with Merkel cell carcinoma. 90% of the cases you will find the virus integrated in the malignant cells. So this is a very rare case. Skin cancer is very aggressive. It's a type of neuroendocrine, and the mortality could be about 30%. Salmonella, we know that some of the patients with Salmonella typhi eventually will be chronic carrier, around 3%. The reason is because Salmonella will form biofilms. If you compare a chronic carrier versus none, the chronic carrier actually have a 200 times increased risk of having gallbladder cancer, and a lifetime risk of 6%. Obviously, you have gallstone, chronic infection, you have a perfect storm. So obviously Salmonella typhi also will go to the gallstones, so it's a higher risk. They found that Salmonella actually secretes some toxin called cytolethal distended toxins. It's also found in E. coli, Shigella, but this basically will cause some DNA damage mutation, also will affect some tumor suppressor gene and overexpress some oncogenes protein also. Liver flukes, cholangiocarcinoma. When I was doing the review, this is the only parasite that they mentioned, like directly affect with some cancer, right? The one is more related to Opisthochis more than Clonorchis. Mechanical injury, chronic inflammation, but also they found that actually the parasite could secrete some nitric oxide, promote the transforming growth factors that will cause some proliferation. So, Campylobacter jejuni, this one was new for me. I don't know if you have heard of this disease. IPSIS. It's immunoproliferative small intestinal disease, also called alpha chain disease. It's a type of MALT lymphoma, but it's in the small intestine, right? So you have the infection, go to the Pyer patches, mesenteric lymph nodes. They will basically promote IgA to secrete alpha heavy chains. So that's the way that actually the Campylobacter promotes this type of malignancy lymphoma. Strep bovie, we know strep bovie, GI, colorectal cancer. So the question is, strep bovie just incidental finding that is growing in the tumor, or actually strep bovie is actually causing some of the tumor cells to grow. So actually they found that strep bovis could actually induce the RAS oncogene. So they think that if you're infected with the bacteria, that also promote the tumor growth. So chlamydia, now Chlamydophilus psittaci. So actually there's a relationship with some mild lymphoma in the conjunctiva. It's around 10% of external lymphomas. So they did a case series on Italy, and they found that 90% of the cases with the lymphoma, they can isolate the psittaci, right? Korea, around 80%. So actually, some of these patients, they treat with doxy. They give radiation and doxycycline for 3 weeks. And they found that the bacteria actually secrete some heat shock proteins that basically is like what happened with GBS Campylobacter. It's like a mimicry. So this protein actually promote the body to attack the tissue and promote the lymphoma. This one, chlamydophila pneumonia, I'm not sure about this one. I'm really not buying this one, but they mentioned that lung cancer. The thing is that you are a smoker. The smoking will promote secretion of interleukin-4. So interleukin-4 actually decrease the immune system to get rid of the infection. So you will have smoking plus a chronic infection at the same time. So that's the theory about that. So, but obviously you are smoking. That's the biggest risk factor, right? So, Borrelia burgdorferi, Lyme's, we already have a lot of headaches with Lyme, so we have another one right now. Weird. The picture didn't show. Yeah, so the picture was cut actually. Okay. So apparently that's a primary cutaneous B-cell lymphoma. I don't know why it's not showing the picture, but Scottish Highland where Lyme's actually a lot of cases. They found that they took 20 cases of the patient, they did a biopsy, and they found that Borrelia, actually they found like 7 of 20 patients was isolated DNA there. Austria, they tried with 50 cases, and around 9 cases where you have positive DNA of the Borrelia there, but they tried to do the same stuff here in the USA, and they didn't find any relationship. So this is not something that's clear.
No causal effect, it's association.
Yeah, so yeah, probably. I don't think it's pictures are getting cut. Yeah. So TB, right? This is escape or?
Well, you could try hitting escape and then come back again. It is going to mimic what's on the screen, so. But it looks like it was cut off there, unless it's.
Yeah. It's okay. It's okay, whatever.
Hopefully it's just limited to those two.
How do
There we go.
Okay, so sorry about that. So TB, so they did a big studies on Turkey and Japan, and they found that patient with lung cancer, they found around 5% of the cases actually have an active TB infection. In the other way, patient with TB, they found like 2% actually have lung cancer. So the pathophysiology is just, you have the cavitation, fibrotic scar, lymphatic obstruction that actually promote the cancer, right? Also, TB overexpress also BCL2. So this one came earlier, February, one of the Dr. Green's emails, right? So this was done on Taiwan. They did a study regarding, was from 2002, 2011. They wanted to see if dengue had to do any relationship with leukemia. So they followed the patient for 8 years, and they found that if you were already, you were previously infected with dengue, they found the incidence of having leukemia will be 17 cases of 100,000. If you are not infected with dengue, it will be 7 out of 100,000, so it will be like double the risk. But obviously this is also observation. There's no evidence that actually dengue could cause, but this is obviously interesting, right? So now, does anyone knows? I don't think anyone knows who is this guy. And then so, but this is William Coley, right? So William Coley is considered the father of. You knew it?
No.
So he's considered the father of immunotherapy. So he was a surgeon Memorial Hospital in New York. He was a sarcoma surgeon. So basically he was very frustrated because he had a lot of patients that actually he didn't have any option like to have any surgery. So basically there was no further treatment. So in 1891 he decided to inject strep pyogens to a patient. The idea was to induce erysipelas, right? So that would stimulate the immune system to attack the tumor. So the thing is that apparently he got some success. The tumor actually shrink. But he wasn't the first one that tried actually doing this. Years before, another physician tried, but he was the one that actually like did like a part of the, his treatment. So he came with the Colorectal. It was a mixture of strep pathogens, also Serratia. The idea is that strep pathogens basically has some oncolytic properties, so it will actually inhibit the angioproliferation, so actually it block the tumor growth. The Serratia, in the other way, secretes some endotoxin from the cell membrane that will stimulate the immune system to attack the tumor. So he actually tried this with around 1,000 patients. Obviously, some of them, this is a picture of a drawing of one of the first patients he actually treated. Some of the patients actually died, septic shock, right? So one of the reasons that, so basically, there's a lot of people that didn't believe in his work because he was not consistent with the toxin, the mixture, how many treatment, the follow-up. People tried to reproduce what he was doing, but they didn't have any success. So on JAMA, actually, he was they called him like a charlatan, actually. They told him that it's not true that the patient that he cured actually was because he had the wrong diagnosis. So eventually the toxin were illegal. But the thing is that I think he was ahead of the time because now we have what is called BMTT. So this is bacteria-mediated tumor therapy. So the idea is that a lot of tumors, obviously, the tissue penetration sometimes is difficult. Sometimes these tumors are necrotic area, hypoxia, so the treatment are basically useless, right? So they think that some bacteria, like for example Clostridium, they can go anaerobic condition, actually could go there and release the treatment there. So also when you do chemotherapy radiation, you're basically killing all the cells, also healthy cells. So with some bacteria, you actually can be selective to the tissue you're going to attack. And there's some bacteria that has some oncolytic potential, and the thing is that probably is even cheaper than chemo, right? So, like I mentioned, so colonization, there's some bacteria, Clostridium, Salmonella, actually could go to some hypoxic necrotic areas. Motility, some bacteria like E. coli, Vibrio, have flagella, right? So you can actually treat several cells at the same time. Immunostimulation, this is not the same as CAR-T, but basically you're using the body to, you infect the area, the immune system just go there and fight the tumor. So, and vectors, you can, for example, Listeria have been used for vaccine for different type of cancer stuff. So, also something interesting, there's bacteriocin. This is a toxin that the bacteria obviously release. The thing is that these toxins are cationic peptides, so they have positive charge. Healthy cells have a neutral charge, and the cancer cells actually have negative charge. So these toxins will be selected to the tumors, right? There have been a lot of studied, E. coli, breast cancer, Klebsiella, even for bird kids, Pediococcus, for colon cancer, Pseudomonas. Obviously, these all in vitro. This is like they haven't tried with patients yet, but this is something that probably in the future, strep bovis, breast cancer, so there's a lot. Even mycobacterium, right? So we know BCG vaccine and bovis is one of the first ones that have been used for treatment of cancer. The first line adjuvant treatment for patients after transurethral resection on non-muscle invasive bladder cancer. It will induce immune response, also stimulate neutrophil macrophage CD4. Also actually will kill urothelial cell death. But obviously disseminated Mycobacterium bovis is a adverse reaction that could happen with these patients. The other ones, Corynebacterium diphtheria. So the diphtheria toxin is one of the first toxins actually being studied for cancer therapy, and they were able to do the first immunotoxin. It's called ONTAC. So basically, it's very interesting. So diphtheria toxin have three fragments, right? Fragment A, they have an enzyme there I think Julie already, yes. Fragment A have the enzyme with ADP, ribosylation activities, the T cell domain, and the fragment B is the binding domain. So basically they took out the fragment B and they replaced it with interleukin 2. So the thing is that interleukin 2 is expressed in a lot of T cells cancer, malignancies. So that way the toxin will go straight to the cancer, and there the ADP eventually will inhibit the elongation factor, so basically will stop protein synthesis and the cell will die. So this is FDA approved for cutaneous T cell lymphoma. So this is something is being used right now. Obviously side effects, interleukin 2 is not exclusive for cancer cells, so patient actually could get blind, who have GI symptom, capillary leak syndrome, so obviously severe side effects. Pseudomonas, the key with Pseudomonas, exotoxin A, right? This is the key with Pseudomonas here. So what they did is they create immunotoxin with the Pseudomonas toxin and antibodies against CD22. So CD22 is a lot of B cells cancer express CD22, right? So they did first BL22, eventually they improved and they now have this moxetumomab, I don't know how to pronounce that, but this is also FDA approved for resistant hairy cell leukemia. So it's very simple, right? Combine the toxin with the antibody, go to the leukemia cell, go there, and the toxin is very similar to Listeria. You go there and inhibit the protein synthesis and the leukemia cell would die. So Listeria, so the thing with Listeria is that we know Listeria is a intracellular pathogen, right? So it goes straight to the antigen presenting cells. And also I think you also mentioned this, right? Listeria have a toxin that is called Listerilizing O. Basically, that's the way Listeria is able to escape being killed in the cells. That's the way they evade the immune system. So they can actually go to the cytosol and keep infecting cells. So this is important. I'm going to explain later for the vaccine. So they're doing a vaccine for breast cancer. They basically took Listeria and they combined with tumor from the HER2 tumor antigens. So the key here is that, so this is a very busy slide, but the Listeria go to the phagosome, right? There's two options. Either it's killed with the phagolysosome, and in this way you're stimulating the CD4. So basically, remember, you have antigen for the cancer there. So basically you're stimulating the immune system to go there and attack other tumor cells. Or either the Listeria can escape. In this way, you will be stimulating the CD8, so you actually have direct killing of the tumor cells. So Clostridium. So with Clostridium, basically, they have to basically delete the alpha toxin gene because patients also were risk factor or going in shock, right? So they came with the Clostridium novae NT. The good thing about Clostridium is go to anaerobic condition, right? Like we mentioned, and also, so it could be a good vector for to deliver cytokine, a lot of stuff. But the most important thing I was reading is that Clostridium actually create antibodies to the hypoxia-inducing factor 1. So basically, this is what the tumors are able to survive hypoxia because of this. Basically, you take this out, cancer cells, they can survive, basically. So Clostridium have antibodies against these factors. So right now, there are phase 1 clinical trial for metastatic retroperitoneal leiomyosarcoma. Actually, one patient had a metastasis on the right shoulder. They inject the Clostridium there. Apparently, the tumor disappears. So this is a mouse. This is not a person, but you can compare radiation alone versus combination of both. And you can see on day 10, actually, the tumor just disappeared completely. Salmonella. So Salmonella, one of the key step with Salmonella is that it's a strong inducer of the inflammation pathway. So this is very important for avoiding tumor growing. So also they have to modify some genes of Salmonella, especially the MCBB gene, because with this way they decrease the TNF toxicity, so less side effects. Also with the other gene, they were able to colonize more selectively the tumor cells. There's been a lot of different serotypes that have been studying, but this one, the Ty21, this is the one that we use for the typhoid fever vaccine. So they're trying to combine with other vaccine to possible treatment for melanoma, colorectal cancer, lung, and pancreas also. And this one, the A1R, actually is the one that is more promising. Right now they're trying to do a HER2, to treat HER2 cervical cancer. So this is with mouse, right? A, no treatment. B is a treatment with carboplatin. C, trastuzumab. D is with the Salmonella, and then E is you combine both of them. They found that you will have better results. So this is just an illustration that Salmonella could actually go to the necrotic core of the tumor cells. There's others that are being currently studied. This is just clinical trials. Limitations, obviously, you're injecting a bacteria to the patient, side effects. The other thing is that actually, so if you, obviously if you inject a bacteria, the body eventually will have create antibodies to the pathogen, right? So the question is that if you give another treatment, again, like a rechallenge, probably the body will just destroy the treatment, the bacteria, so it will not have any effect. So they're thinking maybe if they can remove the T cell epitopes, basically that's what the T cell actually recognize, you can decrease the immune system response. Also, even though you're more specific to the tumor cells, the inflammation is so severe that you can actually affect healthy cells. So they're thinking maybe instead of killing the tumor, just doing some bacteria that actually could just block the metastasis of the cells, cancer cells. Another thing is that solid tumors sometimes they have different properties, so you have limitation to the liver, to the cells. But they came with something that I was surprised. Oh my God, yeah. So this is, yeah, whatever. So basically, this is called a bacterial rabbit, right? So basically, it's a capsule. Inside of the capsule, they will deliver drugs or even bacteria, and with they're the flagella. They're using Salmonella, so they are able to just basically take the capsule to the body. It goes straight to the tumor because you have a capsule. The immune system will not be able to recognize the bacteria, so you will not stimulate the immune system. So that's what we're thinking. Maybe this is the future regarding all this bacteria treatment. So. They're thinking maybe using biofilms. So the idea is that, for example, with Salmonella, you create a hemorrhage in the tumor, biofilms, and you could create a capsule that avoid further metastasis, and also Strep agalatia. Apparently, it secretes some polysaccharides that, in that way, inhibit cancer cells to actually stick to the endothelial cells. So. Now, so anyone hear about this stuff? I don't know. Mlagic. So this is Mlagic or T-BAC. Basically, this is HSV1. So this was approved for metastatic melanoma. This is FDA approved. So the thing is that the idea is that you inject the virus to the lesion, right? So the virus will not affect the healthy cells, but in the cancer cells, they will secrete GM-CSF and toxins, so they will lyse, kill the tumor cell. But that's one of the steps. The other steps is that because you have GM-CSF, that will attract dendritic cells, so the T cells will be able to identified the tumor cells. So now these cells can go to the different places from the metastasis and actually get rid of the tumor cells. So this is something that is already approved. And they're doing a phase 2 trial for malignant glioma. They're using polio and rhinovirus. They're injecting straight to the tumor cells. Right now it's a phase 2 study, so let's see eventually. Maybe they will have some good results. So that's it.